us. Hi, Sarah. Sarah, good to see you too. Oh, she's still connecting. Hi, Sarah. Good to see you, that you made it. And we have a couple more people joining us. Give them just a minute to settle in. Great. Okay. Hope a few more people come join us. Yeah, if you want to just put your name in the chat box and where your I guess your work is, like your workplace or position or whatever it is. Thank you. And I guess I'll get started on the introductions, introductory slides, and hopefully more people will join us as we go along. Okay, so welcome to ECHO. Next, this is ECHO Geriatric Clinics. Next slide. Okay, this is where you can get free CME via distance technology, online learning, opportunity for case discussion. And we have our interdisciplinary team here. And this is a community of learning that we're all going to teach, all learn. That's the motto for ECHO. Next slide. So yeah, if you have any cases, any geriatric topic, doesn't have to be pertaining to today's learning session, but that's what we're here for. We want to share our collective wisdom and experience, and we love challenging cases. So any geriatric topics would be great, but please share them in a HIPAA compliant way. Next slide. So we want to maintain and safeguard the confidentiality of information shared. So all presentations have to be HIPAA compliant. And of course, we want to foster a safe, encouraging learning environment. Case consultations do not create or otherwise establish provider-patient relationships between any of these ECHO specialists and patients whose cases are being presented in this setting. Next slide. And in order to receive CMEs, after you've registered, which you have, in order to get in here, you have to complete an evaluation, and the link for the evaluation will be put up towards the end of the session. Next slide. And Zoom logistics, you know about the chat tool at the bottom. We want you to enter your name and others joining today's session who are in the room with you. And then there's a mute button. Make sure that it's clicked on mute so we don't get extraneous noise, but we would love for you to unmute it so that if you want to speak and share. And of course, you can use the chat box to type your questions or as you want, or comments as the presentation is going along. And this is our hub team. I'm Dr. Wen. I am course director for the ECHO Geriatrics Clinic, and we also have Sarah Tomkison. Want to wave hi. She is a social worker, licensed clinical social worker with 41 years of experience in geriatrics, health, mental health, and long-term care. She's worked many years at the VA, served at Halikuike in memory care, was a social worker at Central Union Adult Daycare Program, and is currently at Straub. Don't see Lucas Morgan here today. And we also have Mary Gotham. Hi, Mary. And she is a retired public health nursing from the Department of Health. And we have Chad. But the good neat thing about today is, next slide, Chad is also our guest speaker. So Chad, he has a lot of credentials. He's an assistant professor of pharmacy. He is from Oahu. He graduated from Oregon State University with a PharmD degree. After graduation, he did his postgraduate year residency at Queens Medical Center. And following residency, he worked as a clinical pharmacist at Queens, Tripler Army Medical Center, and the Department of the VA Pacific Islands Healthcare System. And he's currently an assistant professor and a Geriatric Academic Career awardee and a Robert Wood Johnson Foundation Clinical Scholars Fellows. So thank you so much, Chad, for speaking with us and sharing with us today's topic.
Hi, thank you so much. Thanks for the warm introduction. I'll go ahead and I can share my screen and drive. All right, there we go. All right, well, thank you everybody for taking time out of your day to come and listen to this presentation. So today we're going to talk about a very important topic on an approach to renal dosing and renal drug dosing in the older adult. I get these questions a lot of like how to renally adjust medications, and truly it's a process. It's not just simply calculating a creatinine clearance, looking at a number and crosswalking that with a dosing recommendation. There's so much more that's involved that goes into the process of appropriately renal drug dosing for our elderly. So we'll go into an approach. We'll go into that approach today. So like any learning, like any, any talk, it comes with some learning objectives. And so we're going to kind of understand some of the mechanisms and the physiologic changes of aging. We can't have a discussion while this is a renal dosing discussion. We can't fully appreciate renal dosing unless we understand how all of the different organ systems work together in terms of how drugs move through the body. So the pharmacokinetics and the pharmacodynamics of medications. And then we'll put that all together to develop an approach to renal dosing in some of our elderly. All right, so here's the bottom line up front. Renal dosing is highly individualized. It's not like where you can just, you get a number and you cookie cutter it and you come up with a dosing. A young person with one chronic disease taking just a few medications has a lot of physiologic reserves. And they can sustain extremes in drug dosing. Meanwhile, elderly people with many chronic diseases who are on several different medication regimens already have impaired kidney function, whether we know it or not, low physiologic reserves, making them more predisposed and prone to injuries and adverse effects, especially when it comes to inappropriate renal dosing. So for that reason, we must be aware and be more aggressive in really adjusting our medications. So where does this all kind of root in here? Here in geriatric echo and in geriatrics, we talk about the 4 M's, right? The 4 M's of an age-friendly health system. We talked about what matters, mentation and mobility, but here we're focusing on medication, right? So if medications are necessary, use age-friendly medications that do not interfere with what matters, mentation or mobility. Now, if we do not appropriately renally adjust our medications, it could significantly impact mentation, causing harm and impacting mobility. So this talk today is intimately tied into the 4 M's, specifically on that second bullet point of medication. And of course, it all ties in to the North Star that I call what matters, right? All right, so just as an introduction, the aging associated with physiologic and homeostatic alterations that contribute to the pathogenesis of chronic conditions also influence the responsiveness to medication. So as we get older, some of the changes in our body alter the way our body acts and reacts to medications. The differences and the changes as we get older adults, like I mentioned before, are far more likely than younger adults to suffer from medication adverse events. So what are some of the we're going to just touch on this briefly, but what are some of the human aging and changes as it relates to changes in drugs? Oops. So, well, first of all, like age is, elderly is defined as an age of 65 years or older, and it's not based on physiologic function, but merely Medicare, right? Medicare and Social Security. There's no clinical definition of age that exists. I submit to you that these ladies and gentlemen here at age 65 are in far better shape than I am, and far, they're older than me. And I'm not sure I could stand on my head like that, nor have that type of physique. So again, elderly is defined as greater than 65, but again, it's not based on physiologic function. So we need to make sure that we keep that in mind. As we get older, though, there are some clinical manifestations and the body changes. There's reduced ability to adapt to physiologic stress due to decreasing functional reserves, increased vulnerability to disease. Needless to say that there is individual variability as far as how rapidly, rapidly we age, and people age at different rates, and people develop disease at different rates as well. And we need to take that into consideration. For example, not all 65-year-olds are of equal health and of equal functional reserve, and nor would be the same, could be said to be the same for our patients who are 90 years old. So looking at some of the general age-associated physiologic changes, when we compare our elderly with younger adults, elderly patients generally have more body fat, less total body water, lower muscle mass, lower serum albumin, decreased stomach acid and GI motility, decreased renal and hepatic function, to the point of like some of the organ systems actually decline at a rate of about 0.8 to 0.9% per year. And we start to see some sensory changes in vision, hearing, and taste. There are other age-associated physiologic changes, such as, in the aggregate, a reduced functional reserve capacity. So the ability of your body to respond to physiologic changes or stress, i.e., that's why sometimes when we have a urinary tract infection, it negatively impacts cognition. And then a reduced ability to maintain homeostasis. How does this manifest in medications? Well, the aggregate, the clinical response to a medication is the aggregate. It is the net result of the interaction of that drug on all of those complex processes and organ systems that also include pharmacokinetics, specifically ADME, absorption, distribution, metabolism, and excretion, and pharmacodynamics of how the drug works at the receptor site and how it nests there. All again, the age-related changes in physiology affects the PK and PD. So basically everything plays a role in how our patients respond to medications. So let's really quickly go through a real quick pharmacokinetic refresher. Chronologic age is a significant predictor of individual pharmacokinetic parameters. So, I know I said age is a number, but it is still a significant predictor. Age-associated changes in absorption, distribution, metabolism, and elimination are more important predictors of altered pharmacokinetics than age. So let's talk about absorption. I'm going to just summarize this one really quickly. In general, absorption is not affected as we get older. There are a couple of things that might be affected, but if you just want to, I'm an 80% kind of guy. So I remember just like the big rocks, right? So the big rock here is that absorption is not typically altered. Now, frailty might be might have something to play there, but again, let's just assume that absorption for the most part is preserved. There are, again, this is some of the 20%, right? So there are some certain situations. I'm going to kind of glaze over this for the sake of time. Distribution is altered, though, significantly. As I mentioned before, increasing in, as we get older, we have more fat tissue and decreasing muscle mass. And certain medications are more hydrophilic or more lipophilic. And depending on the property of the drugs, it kind of tells you where the drug likes to live in the body, like whether it wants to distribute into the blood, stay in the blood, or if it wants to distribute into fat. And these changes in the volume of distribution can have a direct impact on the amount of medication that must be given as a loading dose. That is, it affects the way we dose our medications in the elderly period. So we're not even talking about renal dosing yet. We're just talking about where the drug lives in the body, because as we get older, we still might need to adjust a medication because of the changes in volume of distribution. So we need to keep that in mind. Decreasing total body water, has a smaller, that is that the drug has a smaller volume of distribution. It likes to stay in, it stays in the blood basically, rather than distributing into fat. And if you have a drug that, if there is decreased serum albumin, if the patient is frail or malnourished, there's a lot of drugs that are highly protein bound. For example, phenytoin and warfarin. Those are very classic drugs. And therefore, if those drugs are very highly protein bound and you have less protein, then the toxicologic effects of those drugs is increased. The liver is a major organ responsible for drug metabolism. Overall, for many processes, drug metabolism is preserved. It is, the cytochrome P450 system is thought to actually kind of decrease a little bit, but for the most part, I tend to think of it as just a slight reduction in metabolism with respects to the phase 1 types of metabolism with your cytochrome P450. Now, your phase 2 reactions like acetylation, sulfonation, glucuronidation, there's no change in drug clearance as we get older. So drugs that are metabolized through some of those reactions are preserved. We see that a lot in terms of how that manifests. We see that a lot in terms of our benzodiazepine metabolism. So, in geriatrics, we all know that benzos are bad, but sometimes you need them. And so we take advantage of the preserved metabolism, so phase 2, as it relates to benzodiazepine selection. So if you can remember a lot, lorazepam, oxazepam, and temazepam, those benzos tend to be, and I put quote unquote, safer because they are metabolized primarily through phase 3 reactions. That is, that there is no change in clearance. In addition, they tend to be a little bit more hydrophilic, and so that they don't distribute into fat quite as much. Diazepam, for example, is highly lipophilic and therefore goes into a lot of the fat deposits, has a tendency to build up in the population, is not necessarily cleared through phase 2 reactions, and therefore has a tendency to accumulate. And now moving on to the kidney. Renal excretion is a primary route of elimination for many drugs and metabolism. Renal function progressively declines with age. So as we get older, our GFR drops by about 1% per year past the age of 50. Therefore, by the age of 85, it's about 50% of what it was when we were younger at 25. Now, it's important to understand that serum creatinine as a marker by itself is a poor predictor of renal function in the elderly due to reduced lean muscle mass. So just looking at the serum creatinine, in other words, like looking at the lab and then making an assessment. The best way to make an assessment of renal function in the elderly is to use to calculate or to estimate. And one such formula is a Cockcroft and Gault. Now, we'll talk about some of the pitfalls and the fallbacks. Nothing's perfect. So we'll talk about that a little bit later. It is important to note, though, that there are many different ways of estimating renal function: GFR, eGFR, MDRD, many different calculations. Cockcroft and Gault is not perfect, neither are those. However, the FDA does its studies and dosing guidelines for medications. If they're primarily renally cleared, they base it using the Cockcroft and Gault equation. So to be in line with the studies and FDA dosing guidelines, Cockcroft and Gault is what is used for estimation of renal function as it relates to drug dosing. The current consensus is that we continue to use Cockcroft and Gault equation for renal drug dosing in older adults. All right, but now it's important to understand the limitations, keeping in mind that not all patients experience age-related declines, and so sometimes Cockcroft and Gault can underestimate creatinine clearance. Other times, if you have a patient who has loss of muscle mass beyond normal aging, that is, their serum creatinine is less than 1 or 0.07. In these cases, because of I have the calculation and the equation at the end, but if you look at where the serum creatinine is in relation to the equation, serum creatinine is the smaller that it gets because of low muscle mass can actually overestimate creatinine clearance. Now, it's been controversial. Some clinicians will round up to 1, but it is not recommended. it is not recommended to arbitrarily normalize serum creatinine and round up to 1. The reason why we used to do this is because you could theoretically, if you use a serum creatinine of less than 0.0, less than 1, you could theoretically end up with a GFR greater than physiologic. And so people would round it up. And what we found is that that is not recommended. So therefore, when making a decision on older adults, you need to really consider what the guidelines are for renal dosing, understand the limitations of the Cockcroft and Galt, that is taking into the whole patient assessment, and then really digging into the indication, like, what are we treating? What are we treating? What is the drug that we're using to treat? What is its side effect? How toxic is it? And really conduct a risk and benefit analysis. So here are just some drugs. There's tons, right? But here are just some drugs that are highly dependent on renal function. Some of them are classic, like digoxin. Others more recent, like edoxaban, for example. But all of these drugs, if you can look at that, are renally cleared, and some with varying degrees of toxicity. So, for example, if I gave too much lisinopril, or too much famotidine for that matter, I'm not necessarily worried because its toxicity is not very bad. However, if I did not appropriately renally adjust the dabigatran, or perhaps edoxaban to DOACs for anticoagulation, or apixaban even, you could have catastrophic result. So those are just some of the things that I think about when I'm deciding whether or not to renally adjust. So I am this is just an overview slide of some of the different pharmacokinetic parameters, the age effects, the disease factor effects, and some prescribing implications on how to manage those dosing adjustments. Just an overview slide. So that's some of the pharmacokinetic aspects of things. Now let's shift towards the pharmacodynamics. Pharmacodynamics refers to a medication at the actual receptor site, or the site of action, and is largely determined by drug concentration and its ability to bind to the receptor site. Again, because older people can be sensitive to the effects of medication, care should be taken to avoid unwanted adverse effects, especially when starting or stopping medications. So think about not only the pharmacokinetics of things, but we also need to think about the pharmacodynamics of things. So in general, when you combine them two together, the pharmaco-PK and the PD changes generally result in decreased clearance and increased sensitivity to medication. So all of those other slides I just talked about, the bottom line up front is this, is that pharmacokinetically and pharmacodynamically, as we age, all converge to make our patients more sensitive to medications. That's where we generate the geriatric mantra of go low and go slow. So the use of lower doses, longer dosing intervals, slower titration is helpful in decreasing the risk of intolerance and toxicity. So careful monitoring is necessary to ensure successful outcomes. So basically just go low, go slow, monitor the effects, and take it one step at a time. All right, so here's the meat and potatoes of everything that we're talking today. The approach to renal drug dosing in the elderly. We should make sure that we look at all of the patient-specific factors, such as the comorbidity, drug action, drug interactions should be considered and monitored during drug therapy. So here's an example, right? Patient comes into the hospital with the skin and soft tissue infection, and it's MRSA, right? It's MRSA. So we're going to start vancomycin. I calculate the creatinine clearance using the serum creatinine. I calculate the creatinine clearance. But before I look at the serum creatinine, I also have an idea of the frailty and the condition of the patient. So, for example, is the patient frail, cachectic, with rather low muscle mass? I also look at other disease states, like does the patient have diabetes, diabetes, for example, long-standing diabetes. If that's the case, all of these things that I am seeing in the back of my mind lead me to predict that the kidney is not as good, is perhaps not as good as I might calculate based upon a calculation. So I see I get what the calculation says, like I'll run the calculation, but then you kind of like run that against your own clinical judgment to come up with an idea. And then I calculate a vancomycin dose, right? Deciding if I want to be more aggressive or more conservative with treatment based upon the severity of infection. So sometimes I might be a little bit more conservative with the dosing because the infection is not as severe, and I'm more worried about drug adverse event. Other times, I might be more aggressive with my dosing because I am more worried about treatment failure. I also take into consideration current medications, both prescription and non-prescription medications, to identify potential nephrotoxins or interacting meds. So for example, that same patient who is on vancomycin maybe also has Lasix and an ACE inhibitor, both of which can, collectively cause nephrotoxicity. Many times when we put a patient on vancomycin for a skin and soft tissue injury, we might even be on other antibiotics like Zosyn, for example. And those two antibiotics in combination has been shown to increase nephrotoxicity as well. So I'm looking at everything, not just the serum creatinine. I'm looking at like the drugs, interactions, the disease state, risk versus benefit. Then we use the Cockcroft and Galt formula to approximate creatinine clearance, and then we dose adjust. And if we have to, and if we can always check drug levels to make sure we're on point. So in elderly patients in summary, the use of nephrotoxins or just potentially nephrotoxic meds should be limited only in circumstances where the benefits clearly outweighs the risk of nephrotoxicity. So for example, like, if you're going to use a drug that's hard on the kidneys, make sure that it is absolutely necessary, especially with patients who might already be at risk. And here are some of the, here on the next slide are some of the equations that we use to calculate creatinine clearance, and Cockcroft, using Cockcroft and Galt. Sorry, we'll go back. So again, the whole presentation and the point is that on slide 27, going back to slide 27, is that it is very important to utilize a holistic approach to renal drug dosing. Another example is, and I like to use antibiotics because I think it's fairly, tends to be a little bit more cut and dry in my mind anyway. So patient is elderly patient with fairly poor kidneys, is in the ICU and is septic, on pressors, very ill. And sometimes the patient is not getting better despite antibiotic therapy at renal doses. It may be prudent to consider pushing the dose up a little bit, depending on that antibiotic, to make sure we are adequately covering that particular pathogen. Especially in patients that may have that may be a little bit larger, whose VD might be a little bit larger, despite the fact that they have renal dysfunction and the severity of infection, it would be prudent to push the dose to not risk treatment failure and give them the benefit. And we will deal with any particular side effects of that increase of antibiotics as it comes. So if there's further decline in renal function, if there are, other side effects like thrombocytopenia, for example, we will deal with that as we monitor and watch the patient. And so that's my approach that's my approach and recommended approach to drug dosing in the elderly. With that being said, that concludes the presentation, and I'd like to take time for any questions or comments.
Thank you very much, Chad, for a very comprehensive overview. I see a comment from Roxanne. It says, I'd like to go online and use online calculators. Makes the yeah, definitely. I don't try to do it by hand. Plug in the formula.
Yes. Hey, Roxanne. Yeah, good to see you again. It's been a while since working at the VA. Yeah, I use the online formulas too. I do. It is easier, rather than punching it into my calculator and whatnot. And it's just very handy to have. But as always, I do make sure that you crosswalk what the creatinine clearance is with the drug, and then decide whether you're gonna renally dose adjust or not. So for example, common ones I get is like if it's on the cusp, right? Say like you're on an anticoagulant and you really need this anticoagulant, and it's saying renally adjust, dose it down, but then the patient has an active DVT. So do you renally adjust and cut the dose in half, or do you keep it the same when, like, say the creatinine clearance is for adjustment is 50. So 50 says you got to drop it and you're at 45. Do you really adjust? Or do you just keep the same dose? I don't necessarily think there's a right or wrong answer, but I think it's something that we need to think about. I think it's something that we need to think about in deciding which way we're going to go.
So I had a question going back to the absorption thing. I know you said it's not a big deal, but a lot of older adults are on H2 blockers or proton pump inhibitors. And so I guess, we just really need to be aware, and we always reconsider the need to continue those drugs because it impacts absorption. But actually, if they need to be on it, how much of an impact is it? Is it really significant or not really even?
So I think it depends upon the drug itself. So there are certain drugs that have a large therapeutic index and those that have a small therapeutic index. So those are the ones I'm most concerned with. So for example, if you're on an antacid and you're taking like a quinolone, for example, for, that you really need to make sure you get good concentrations, then that's significant, right? But if we're talking about other medications that, cholesterol medications or other medications with larger therapeutic windows, I'm not so worried about.
Okay.
There are certain there are certain no-fail meds, right? Like, anticoagulants, antibiotics, like those are like no-fail meds. So I make sure that we maximize the absorption and the utility of those drugs if I can.
Any other questions? Okay, so the other thing is, I guess when we order labs, right? We automatically get these estimated GFRs, right? So that eGFR sort of gives us an idea of what their renal function is, but it's how should we interpret that? Should we still need to calculate the creatinine clearance, right?
We do. And actually I kind of use it as like a it's more information for me, so like if I'm calculating Cockcroft and Galt and I'm showing this thing and the EGFR and the labs is showing something wildly different, then that gives me pause. It should be relatively close, right? And so if it's different, then I need to figure out why it's different and then make a decision on what that means for therapy. I haven't had it wildly different. I mean, I haven't. But it's a good kind of like second check for me.
Okay, so sort of a proxy, but there's caveats, and therefore you need to do the creatinine clearance anyway.
Right. So the proxy is like I'll kind of like look at the, as I'm running through my patients and it has an EGFR, the GFR, then I'm like, okay, yeah, that looks about right. I don't necessarily think I need to go and do a deep dive into all of the different medications, and calculate the creatinine clearance and go line by line on adjusting meds. But if I look at it and it doesn't look good, then I will make a more intensive medication review and renally adjust as appropriate. But again, it's important to note that the GFR or the EGFR is mainly for like diagnostic purposes and drug staging, diagnostic purposes and disease staging, whereas the Cockcroft and Galt is specifically used for drug dosing. So
thank you.
yeah.
Any other questions, comments, or other interesting cases?
I think if there's one take-home message is don't just renally adjust based on numbers. Use a systematic process.
Great.
Okay, so there's a question from Roxanne. What about when specialist recommends medications such as allopurinol, but renal function is impaired? Could it be any med that impairs renal function? So in this case, let me try to see if I understand the question. I'm sorry. So if the patient has impaired renal function and a medication is prescribed, such as allopurinol, then in that case, I would make sure that it's allopurinol, right? So I'm not necessarily, and it has a lot of toxicity associated with it. And so I would recommend in that case starting low and renally adjusting, starting low and then titrating slowly. Especially because of worried about the rashes and the gout flares. So I would recommend starting low and titrating slowly. I would also keep in mind that there are other potential nephrotoxic agents as well. Not sure. Sometimes you just can't avoid it, right? I mean, the assumption is that all of the medications are there for great reason. Not all the time, but let's just assume that it is. So we'll just have to deal with some of those interactions. So if the patient does need allopurinol, I would probably recommend starting low and titrating slowly. I know febuxostat may be an option, but I think it's kind of had a bad rap in terms of like cardiac side effects. So that's something to be aware of too. But so as a proxy, if you have a medication, if you have renal impairment and the specialist wants allopurinol or any drug that's renally cleared and it's going to be problematic, then this is where we can kind of look at some of the other medications and see if there's a medication that we can turn to that's either not nephrotoxic or that is not cleared renally as an alternative.
And that's where we depend on our pharmacy colleagues, right, to tell us.
Right.
Great. Any other questions? Seen any geriatric cases lately?
I'm sorry?
No, so are there any other questions on other geriatric cases lately that you have questions? Okay. All right, so yeah, looks like not too many questions right now. So yeah, if you have any questions later on you think about, please write them down and save it for next time, and we can definitely discuss it then. But thank you for the overview. It's always good reminders to be aware of those things. And then also, I guess with the as you brought up, that cytochrome P450 thing, right? I mean, pretty much like every drug is metabolized by that, and we have to be mindful of that as well.
Yes.
Okay, well, if we don't have further questions, I guess we can give you back some time. You have like 15 minutes left to your hour.
All right.
Thank you
Thank you
so
very
much,
much,
guys.
everybody.
Oh, don't forget to, yes, the link for the CME. Get your CME. So click on the link and just take care of it right now. Okay, see you later. See you next month.